Okay, good morning, everybody. Today I'll be chatting to you about stress echo and as it pertains to ischemia evaluation, and we'll be going over some illustrative cases. So the objectives for today's talk will be to review the indications, contraindications, safety, and diagnostic accuracy of stress echo. We'll go over the workflow for a typical exercise stress echo and dobutamine stress echo. We'll review the principles of regional wall motion scoring. We will go over the literature review for prognostic implications for both a normal and abnormal stress echo, as well as what dictates high-risk features. We'll cover the etiologies of a false positive stress echo and what prognosis that carries. And we'll also touch on the role of stress echo now that we are in a post-ischemia trial era. And as mentioned, illustrative cases will be sprinkled throughout. So the majority of the talk is based on and in line with what is presented in the ASC 2020 stress echo guidelines. Now, that is not where we started, and as Dr. Chow usually likes to ask, who is the father of stress echo or other modalities or other echo-related things? In this case, it was Harvey Feigenbaum, who first published in Circulation in December of 1979, the use of stress echo in ischemic heart disease evaluation. Now, as you see bolded here in red, the studies were technically difficult, but feasible. Fortunately, with both advances in the machines, our ability to now save our images digitally rather than on videotape, and with increase in sonographer skill and comfort with this modality, we no longer consider stress echo to be really technically difficult in most cases. So the indications for stress echo go well beyond ischemia. We can evaluate myocardial viability, LV diastolic dysfunction in a patient with mitral stenosis. If they have symptoms that are not, that are sort of out of keeping with what we see on the baseline echo, we can stress them to see the response of the mean gradient and RVSP during stress. We use stress echo for low flow, low gradient aortic stenosis evaluation to decide whether it's truly severe AS. We utilize it in the HCM population to look for how dynamic their LVOT gradients are and how much MR they have with stress. And then in the pulmonary hypertension population, we also use it to look for increases in RVSP and declines in RV function with stress. Now, for the purposes of today's talk, we will simply focus on CAD diagnosis and prognosis. Okay, so when it comes to the safety of stress echo, it is a very safe test. The data comes from a large study out of the Mayo Clinic. They looked at 15,000 stress echoes performed over 2 years and found that the most common complication was atrial fibrillation, but even that really occurred only in 28 patients. Other SVTs were even less common. Sustained VT or VF, which we fear, were really infrequent and actually exclusively occurred in the DSE population. That's the dobutamine stress echo population. Patients with markedly positive tests or prolonged chest pain requiring admission were rare. Patients experiencing symptomatic hypertension were rare as well. Life-threatening complications were 0.4 per 1,000 patients. There were no deaths. So overall, a safe test, but perhaps slightly more complications in the dobutamine stress rather than exercise stress group, and that is owing to a higher burden of arrhythmias. Now, there are patients who should not undergo stress echo, and this is not to be an extensive list, but in general includes patients who have ACS or ongoing unstable angina. if they have uncontrolled hemodynamically significant arrhythmias, if they have a hemodynamically significant LVOT gradient that you already know about, or severe symptomatic aortic stenosis, they should not be stressed. And then generally, if their baseline blood pressure is greater than 180, we will suggest that that gets under control before we pursue the stress echo in the future. This, of course, in addition to the ones listed here, the typical ones that we, the contraindications for stressing in general, meaning, you know, if they have a PE or aortic dissection or acute pericarditis, also applies. Now, in terms of diagnostic accuracy, I have bolded the contrast stress echo and exercise pharmacological stress echo in red here. As you can see, the sensitivity is ballpark around 82%, and the specificity falls in that range as well. When we compare this modality to myocardial perfusion imaging, we see that myocardial perfusion imaging generally has a slightly higher sensitivity and a slightly lower specificity. In comparison, when cardiac CTA or cardiac MRI are compared to stress echo, those modalities have a higher sensitivity and on ballpark a similar specificity. So what are the implications of a normal exercise stress echo? There is a difference between a exercise stress echo and its implications and a normal DSC. We'll get to the DSC in a minute. In general, if a patient has a normal exercise stress echo, they have an event rate of just under 1% per year for the first 6 years. This event rate is lower in women. The independent predictors of death among patients who have a negative exercise stress echo are advanced age, smoking, a peak heart rate less than 85%, and a higher Duke score. Beta blockers are protective. The story is less simple for a normal dobutamine stress echo. And this is perhaps intuitive because we know that patients who can exercise and those that we are forced to order a DSC on because they can't exercise are just intuitively not the same patient. The DSC patient tends to have more comorbidities. In this study, where they looked at 3,000 patients with a normal dobutamine stress echo and followed them for a median of 6.3 years, they found a very high all-cause mortality of 31% and a cardiac event rate, which they defined as MI or need for coronary revascularization, of 7.7%. The differences increased over time. As you can see, within the first year, the event rates were not terrible. The survival was 95%, and the cardiac event-free probability was 98%. But of course, over time, that increased. The big difference between all-cause mortality and the cardiac events likely points to the fact that these patients are fairly comorbid and have extra cardiac disease that may lead to their demise. This study looked into what were the independent predictors for mortality and cardiac events and found that age, diabetes, and a failure to achieve 85% age-predicted maximum heart rate were independent predictors. In fact, even in a patient who had a negative study but had all three of these risk factors, that patient had a 13% probability of a cardiac event within the first year. So this is all to say that when we have a patient with a normal dobutamine stress echo, it doesn't necessarily mean that their prognosis is particularly good. And so you have to look at the patient a little more holistically. Now, when it comes to the types of stress we have available, in terms of exercise, we typically use treadmill or a supine tilting bicycle. This is what we use at St. Mike's at present. We can also use pharmacological stress. In Ontario, we typically use dobutamine, which is a beta-1 adrenoreceptor stimulator, and that will increase the heart rate and increase the myocardial contractility. In Europe, they use more vasodilator stress, where something like that pyridinol is used, and it will increase coronary blood flow via the adenosine A2 receptor. We don't typically use this in Ontario, and I'm not sure how widely it is used in Canada in general. The other option is to try atrial pacing. This is a bit niche, and if you have questions around it, I'm happy to address them, but for time being, I will not dwell on this form of stress. So the typical layout of a room for a treadmill stress echo is shown here. We have the ECG technician station, as we provide continuous ECG monitoring throughout the test. We have the treadmill where the patient exercises. The bed is close by, as the patient will have to get themselves on the bed for quick image acquisition, and then the sonographer's workstation. The test always starts with a rest echo, which is sometimes called a limited study, but really it's almost a complete study, and involves assessment of LV systolic function, both global and regional, diastolic function, the RV function, all valves are looked at, as well as the aortic root and ascending aorta. Now, sometimes, depending on the patient, you may opt to do diastology just at rest, but let's say that the patient was referred for dyspnea, it may be reasonable to repeat some of the diastolic findings at peak stress. Keeping in mind, however, that once you are tachycardic, you may have EA fusion, and that may limit your interpretation. So once the rest echo is done, the patient is then stressed, usually using the Bruce protocol. We will go over the termination points for the test later. When the patient's stress is done, the very skilled sonographer has ideally 1 to 2 minutes to acquire the post-stress images. And the reason that is because your heart rate, of course, is precipitously dropping as the patient is laying on the bed. And so we don't want to miss that window between a regional wall motion abnormality developing and us acquiring that image in time to see that wall motion abnormality. With supine bicycle stress echo, the flow is very similar. We still have continuous ECG monitoring. The patient is exercising. The protocol now is, of course, different. In supine bicycle, the patient is ideally meant to keep a constant rate of 60 revolutions per minute, but at each stage, the resistance increases such that the METs required to do the activity also increase. The flow of image acquisition is similar, but with slight differences. So the rest echo is the same, but we acquire intermediate stress echo images. This usually occurs once we have achieved 65% age predicted maximum heart rate, and we are at least stage 2. Peak stress echo images are actually acquired while the patient is still exercising, so that we have less trouble with the heart rate dropping like we do with the treadmill. And then once the peak stress echo images are acquired, the patient stops exercising, the heart rate recovers, and recovery images are taken. It's been shown that recovery images being taken can increase the sensitivity of both exercise and dobutamine stress echo. It can also facilitate showing myocardial stunning. So what's the difference between treadmill and bicycle? Well, really, it's not just that one is better than the other, but they have physiological differences. So typically, higher heart rates are achievable with treadmill stress. With bicycle stress, patients seem to have earlier leg fatigue, so that ultimately leads to shorter exercise duration, a lower maximal workload, and a lower maximal heart rate. This is particularly important to consider when you do have a fairly young patient who will have a high 85% age-predicted maximum heart rate. And since we typically use, in practice, we'll say that the test is non-diagnostic if somebody fails to achieve that target. You may find that you're calling more non-diagnostics with young patients when using a bicycle stress. Additionally, bicycle stress, basically, by the nature of the test, leads to a higher preload and afterload, so that what you may see is that it looks like there's less of an increase in contractility and less prominent decrease in LV cavity size when you're using bicycle stress rather than treadmill stress. It shouldn't really interfere with your interpretation, though. When dobutamine stress echo is utilized, again, continuous ECG monitoring, periodic blood pressure checks, and periodic imaging using the rest, intermediate, peak, and recovery time points. Dobutamine is infused starting at 5 mcg per kg per minute and increased all the way up to 40. If we notice that at around the 30 mcg mark, we're unlikely to achieve 85% age-predicted maximum heart rate, this here is a target because we don't have any other target, i.e. patient exercising to exhaustion, not exhaustion, but maximal exertion as a target. So this has to be used as a surrogate. If we feel we are not going to achieve that with dobutamine, then we can start adding atropine. An important consideration when referring someone to a dobutamine stress echo is to hold their beta blockers for at least 48 hours so that we're not getting into trouble with meeting this target. So when do we terminate a test? Well, you will terminate it irrespective of whether you've met any diagnostic endpoint if the patient has intolerable symptoms and wants to stop, if they have muscular exhaustion, if they have severe hypertension, which for both men and women is now in this iteration of guidelines defined as a systolic of greater than 220 or a diastolic of greater than 120. If they have symptomatic hypotension, or if they have a sustained slash hemodynamically significant arrhythmia. The diagnostic endpoints are listed here. A workload of at least 80% predicted for age and sex is used as a guide. You will not be stopping the patient if they can go higher than 80%. Marked ECG positivity, obvious echo positivity, or severe chest pain where you would want to stop the test. An abnormal test is defined as either symptomatically positive or a surrogate of symptoms. Ischemia, as shown by new or worsening regional wall motion. Development of a sustained arrhythmia, or some other finding, and that other finding is usually related to when we're doing the stress echo for another indication like diastology, where E over E prime of greater than 15 is associated with a higher wedge pressure, and therefore it's a diagnostic endpoint. Now, I just want to draw your attention back to this point. You may be surprised that they're using workload rather than 85% age predicted maximum heart rate as a marker. Workload here refers to the METs that you're expected to achieve, and there are published nomograms that you can use to identify what that predicted workload is. Why the guideline chose this as their diagnostic sort of threshold is not per se based on any study. It's simply an arbitrary kind of set point that they decided to use. And with the rationale that a failure to achieve that 80% workload would diminish the sensitivity of the test. In practice, we do still rely on the 85% age-predicted maximum heart rate as a marker of adequacy of exertion, but it's important to be mindful of the limitations of using this. One, it has never been validated as a termination point for an exercise test. So we shouldn't be simply stopping the test once the patient has achieved 85%. We should allow them to go to development of symptoms, development of one of those other ECG or echo findings, or simply that they have achieved their Borg 15 level of exertion, meaning that they feel they are working hard. Even when we, and the reason for that is it's not been validated, and using it is sort of also quite arbitrary as a cutoff. It's loosely tied to the finding that when patients can't achieve 85% of their age-predicted maximum heart rate, they're defined as having chronotropic incompetence, and that does carry a poorer prognosis. But it is not a good marker of adequacy of exertion. And if we use the gold standard, meaning do a cardiopulmonary stress test and get a patient's peak respiratory exchange ratio, so the maximum CO2 produced to the oxygen consumed, that is the objective way of measuring maximal exertion. That time point, that peak and 85% age-predicted maximum heart rate do not correlate very well. In fact, the patient's self-perceived exertion level correlates better. So that is why we say let the patient exercise to when they feel they are working hard. Additionally, the 85% age-predicted maximum heart rate has a poor sensitivity for the detection of future CV events in otherwise negative ESC studies. And for that reason, studies have been conducted to try and find a better marker of prognosis. One of those better markers is the heart rate blood pressure product, which is basically when you take the heart rate and multiply it by the systolic blood pressure. In this study, they found that patients who achieved 85% age-predicted maximum heart rate, but failed to achieve the threshold for the rate pressure product of 25,000, they had more CV events than patients who did achieve that threshold, irrespective of what maximum heart rate that other group achieved. So in our St. Mike's echo reports, you will see this number, the rate pressure product quoted in the report. Okay, so we'll now get through to what images are we acquiring? We acquire a peristernal long axis, short axis, the apical 4, 2, and 3 chamber at each of those imaging stages. Each segment is, the LV rather, is then segmented into a 16 segment model, with the base and mid LV being segmented in 6 components and the apex into 4. Each one of these segments is then scored. The scoring is shown here. A score of 1 means the wall motion is normal or becomes hyperkinetic, meaning systolic thickening of greater than 50%. A wall motion score of 2 is what we use for hypokinesis, and that's defined as systolic increase in thickening of less than 40%. Wall motion score of 3 is used for akinesis or severe hypokinesis. 4 is what we use for dyskinesis, and remember, dyskinesis is basically paradoxical systolic motion, so it's when in systole, instead of things coming in towards the center of the cavity, they're moving away. And then we score 5 for aneurysmal wall motion, and we call something aneurysmal when you see it deformed in both diastole and systole, versus dyskinesia, you won't see that deformity in diastole. So some of you may be wondering why all this focus on thickening and not inward motion, which isn't that what we usually look for? Well, as you advance your stress echo interpretation skills, you actually tend to rely more heavily on thickening, because you come to realize that inward motion can be due to translational change or the pull of an adjacent segment, rather than the intrinsic contractility of that segment of interest. And so basically looking at systolic thickening is more reliable. Once each of these segments is scored, the score is summed up and then divided by the number of segments that you scored, and that gives you the wall motion score index. Perhaps intuitively, we call normal wall motion when things go from normal to hyperkinetic. We call ischemia when things go from normal to hypokinetic or akinetic or dyskinetic. We call viable ischemic myocardium when there's a wall motion abnormality at rest. It improves at low stress and then goes back to being less well thickened at peak stress. We call viability with non-ischemia when we start off with wall motion and the improvement in wall motion is sustained throughout the test. And then infarction is if there's a wall motion abnormality at rest and there's no change. If a particular segment goes from akinetic to dyskinetic, that's just an infarct and not a reflection of ischemia. So one of the other major components of looking at of interpretation is providing the reader with a coronary territory for the wall motions that you've seen. And for your reference, the territories are shown here. So we'll now get into some cases. Our first case is a 69-year-old gentleman with CCS class 2 to 3 symptoms over the last 4 months. He has begun to modify his physical activities to avoid chest pain. He has cardiac risk factors that include dyslipidemia and active smoking. He's on the medications outlined here. The anti-anginals are not really up-titratable any further because of his vitals and side effects. And he is now referred for an exercise supine bicycle stress echo with Definity. So just to provide you with reference, this is our peristernal long axis view. We have the rest images, the intermediate images, the peak images, and the the recovery images shown here. I will go through all of the videos and then give you some time to do your own interpretation before we go back and interpret together. This is again the peristernal short axis at rest, intermediate, peak, and recovery. The apical 4 chamber. The apical 2 chamber. The apical 3 chamber. And then a question for you. So what does the exercise stress echo show? A normal steady, RCA ischemia, LAD ischemia, LAD and left circumflex ischemia. So if we go back to the peristernal long axis view, let your eye have a look at both the intermediate and the recovery images here. In recovery, you can see that the cavity nearly obliterates and the apex is nice and pointy. Versus in the peak images, we see that there's a bit of a hinge point at the mid anteroseptum, and the apex is sort of not doing much at all. The peristernal short axis views can be helpful. And I typically look at them at the very end once I've looked at my apicals to sort of correlate what I've seen in the other views. It's also helpful to look for LV cavity dilatation with stress or a decline in EF in these views. So in this case, if we look at our recovery, we see the LV is nice and snappy, versus if we look at our peak, we see that there's quite a significant wall motion abnormality both at the anterior and the anteroseptal and the anterolateral segments. And the cavity looks quite a bit bigger at end systole than at rest or in recovery. In the apical four-chamber, you can appreciate that the apex looks nice and pointy at rest and in recovery, versus at peak, the apex seems to have that sort of a thumbprint appearance. In addition, we can appreciate that the mid to distal anterolateral wall is hypokinetic. Similar findings here, with the apex looking less pointy at peak, and there being a hypokinesis of the mid to distal anterior wall. In comparison, the inferior wall here looks like it's thickening very normally. And then in our apical three-chamber views, we see very similar findings to, we have a frozen screen here, to what we saw in the parasternal long axis views. So in our interpretation of this case, we found that the patient had a clinically positive, electrically equivocal, and echocardiographically positive study with the wall motion abnormalities as shown. This was suggestive of mid-LAD territory ischemia. We also noted that the EF declined at peak stress and LV cavity dilatation occurred. These were eyeball assessments, and the wall motion score index was 1.44. So what does this mean for this patient? What are the prognostic implications? Do you think this patient had a low risk, intermediate risk, or a high risk stress echo? So let's go over some of the literature to decide. Wall motion score index has been studied fairly extensively. In this particular study, they looked at 15,000 patients with suspected CAD who underwent stress echo. They followed them for just around 3 or so years. And they found that the cardiac event rates were significantly higher if the patient ended up having a higher wall motion score index at peak, and high was indicated as greater than 1.7. If this population was further stratified according to the resting LVEF, we get a little bit more refinement in risk. So on this graph, what you see is the shaded columns are patients with an EF of greater than 45% at rest, and the patients with black columns are those with an EF of less than 45%. So really the patients who have both a high wall motion score index and a poor resting LVEF are at highest risk. Another marker of poor prognosis is having a high number of segments involved. So in this study, there's an exponential increase in event rates if you have greater than or equal to 3 segments involved. Transient ischemic dilatation is another marker of prognosis. How we define TID varies, as you'll see in studies. In this particular study, the LV end diastolic volume ratio between stress and rest was examined, and a cutoff of 1.17 was picked based on ROC curve analysis for the detection of cardiac events among just 116 patients who had both stress echo and coronary angiography. And what they ultimately found is that patients who have a normal stress echo and no TID have very low event rates, versus patients who have TID and an abnormal stress echo have very high event rates. And pretty much everybody in this group ended up having multivessel CAD on their cath. Now, like I said, how we define TID is not uniform across studies. In this particular study, which is a bit more contemporary, they actually found that it was end systolic volume at stress to rest that correlated better with greater than 3 segments of stress-induced ischemia. And the cutoff that they found was a percent change of greater than 9%. Now, you might be thinking, oh boy, am I measuring end systolic volumes? Generally in clinical practice, we don't. We just eyeball it. I did not find a study of, if they compared eyeballing it versus actually measuring it and how that performs. But generally, that is how it's done in clinical practice. Another marker of prognosis is what the exercise LVEF does. So in patients where we see the EF drop, cardiac deaths are significantly higher in that population compared to those where the EF does not significantly drop. And again, this is in clinical practice an eyeball assessment. So in our case 1 patient, we have someone who has a decline in LVEF, LV cavity dilatation, a sort of intermediate wall motion score index, and the mid-LAD territory implicated. So this is an intermediate to high risk stress echo for this patient. He ended up going on to have cath, and we have good correlation. There was a 95% mid-LAD lesion. There was also a 90% proximal OM lesion. So when we go back and look at the stress images, it was a judgment call whether we called the sort of infralateral wall as well. We didn't in this case. Both of these lesions were stented as the patient was still having angina and on his essentially on maximal anti-anginal therapy, although there were other risk factors that he still requires to be modified. So case 2. In case 2, we have a 57-year-old man with 2 episodes of typical chest pain with brisk walking in the cold. Once the springtime came, his symptoms seemed to dissipate. His cardiac risk factor is dyslipidemia. His past medical history is of unprovoked DVT, and he's on rivaroxaban. So I'll let you review these images yourself. They are meant to drive home a concept that we learned about in the previous case. As you can see, the wall motion abnormalities are looking at this point very similar to the last case. In this case, we can perhaps appreciate a bit more hypokinesis and pretty much near akinesis in the infralateral wall. So ultimately, the findings in this study were that the patient exercised for a very solid amount, 13 minutes and 24 seconds, achieving 175 watts and just almost touching that greater than 2500 mark for the heart rate blood pressure product. His stress echo was clinically negative, electrically negative, but was echocardiographically positive, as you saw, at 81% age predicted maximum heart rate. Ultimately, we implicated the LAD and left circumflex territory. His wall motion score index was 1.6, and we did feel that at peak his LVEF had declined and his LV had dilated a bit. So he too went on to have a cath, and unlike the last patient, his findings were a bit different. In this case, we found that the left main was normal. The LAD was fine up until the very distal portion, which was very diffusely diseased. The first diag had an 80% proximal lesion and again diffuse disease distally. His OM1 and OM2 were both heavily diseased, and including very much distally. So, but the RCA was normal, which is not shown here. So with all this diffuse disease, he was felt to be not a particularly attractive revascularization candidate, and he himself had a preference for medical therapy. So that's what was decided for with him as a management strategy. So how do we feel about this management strategy? Does evidence support simply having this patient on optimal medical therapy? Well, the trial that we sort of look to for reassurance in this case is the ischemia trial. As you know, ischemia trial examined stable CAD patients who'd had a stress test that showed moderate or severe ischemia. That stress test could have been a GXT myocardial perfusion scan or stress echo. The major exclusion criteria are shown here. In addition to what you see here, having left main disease was an exclusion criteria. We'll get to that in a minute. Everyone who was ultimately enrolled was considered for a coronary CTA. Patients who had an eGFR of 30 to 60 were not given a CTA due to their CKD. And patients who had anatomy previously defined over the last year were also not given. So ultimately, the patients who got randomized, 73% had a coronary CTA. That CTA was evaluated by a core lab, and patients who either had left main disease or clearly had non-obstructive CAD, meaning their stress tests were false positives for significant epicardial disease, were excluded. Those false positives accounted for about 20% of the CTAs. So once all this was done, the patients were ultimately randomized into the invasive group, which was provided optimal medical therapy, a cath, and then optimal revascularization if possible, versus the conservative strategy where patients were given optimal medical therapy and followed, and if they failed optimal medical therapy, they then went on to have a cath and revascularization as appropriate. The median follow-up was 3.2 years, and the primary endpoint was a composite of CV death, MI, hospitalizations for cardiac arrest, heart failure, and unstable angina. The primary outcome results are shown here. Ultimately, there was no significant difference in the primary outcome. There was a bit of a blip early on that suggested at 6 months that the invasive group was more poor off compared to the conservative group. But this finding is largely secondary to the higher procedural MIs. By the time we come out to 5 years, there is no difference between the groups for primary outcome. However, you do see the curves cross, and the question becomes, well, if we followed these patients out to 10 years, would we see a difference? And there's no way we can't predict the future. We'll have to wait and see what the data shows. But at present, at least from what we see here, we can be a bit reassured that a patient who does meet enrollment criteria for this trial and is placed on medical therapy is safe to be simply on medical therapy and followed. Now, I'm really only telling you about 50% of the ischemia trial story because the way myocardial infarction was defined there were two definitions, and that did change a little bit of how the trial was interpreted. But ultimately, I won't get into that discussion today. I can if we have time, because it doesn't change the bottom line, and that being that we're still safe to start patients on medical therapy and follow them despite them having a disease like our patient did. At least we think so. I mean, how many patients had the diffuse disease that our patient had in the ischemia trial, we're not sure, but that's the best sort of evidence we have for time being. Okay, so case 3 is a 58-year-old female, and she's referred actually with dyspnea and MID over the last several months, and she's noticed that occurring after a couple of flights of stairs, which wasn't her usual. She was used to hiking previously and feeling fine. She denies any chest pain. Now, right off the bat, you might be thinking, oh, like she's referred for dyspnea, not chest pain. What does that, mean? Well, basically, when they've looked, patients with dyspnea compared to patients with chest pain referred for exercise stress echo actually seem to have a worse prognosis. So we should take these patients seriously, and certainly having them undergo an exercise stress test is appropriate. So her cardiac risk factors included hypertension, and she was otherwise healthy. Her medications were antihypertensives. When you saw her for her stress test, her baseline blood pressure was a bit elevated at 160/90. Her baseline echo, I will tell you, was normal. So this is her study. Certainly comparing this recovery image to her peak image, there's a marked difference with the entire anterolateral and apex looking severely hypokinetic. And the same goes for what we see in the apical two-chamber. Here, even the inferior wall is not thickening very well compared to what we saw with our other cases. And again, the infralateral and the entire anteroseptum is implicated. So based on the exercise stress echo that I've shown you, what would you anticipate you would find on coronary angiography? Flow limiting triple vessel disease, flow limiting left main stenosis, or normal coronaries? I'll let you have a think about that, and you can answer the question for yourself. Before we get to her coronary angiogram, just show you a summary of her findings. So she went 6 minutes, clinically negative, electrically equivocal. Her wall motion score was 2.31, and as you saw, she did have some LV cavity dilatation and decline in her EF. Notably, her blood pressure was 180/106, so not per se a hypertensive response, but the diastolic is high. When she went to have her coronary angiogram, however, she was actually found to have normal coronaries, and she remained hypertensive throughout that cath. So the suspicion was that perhaps what we're seeing is a reflection of hypertension, which is known to give false positive stress echoes for epicardial CAD. Other potential causes, especially in this patient, for a false positive would include microvascular disease, since we don't routinely look for sort of ancillary findings on cath for microvascular disease, and we certainly didn't in this case. Another possibility for false positive stress echo is non-ischemic cardiomyopathy that is sort of subclinical at rest. A dysynchronous septal wall motion, either due to left bundle branch block or RV pacing, not in her case, but a possible cause. Systolic anterior motion of the septum that we sometimes see after open heart surgery. And then other causes are a localized basal inferior wall motion abnormality, because this tends to be overcalled on stress echo or other interpreter bias. So what are the prognostic implications when we do have someone with a false positive stress echo? Well, it seems to happen a fair amount. In a study of 1,400 or so patients who both had a stress echo and coronary angiogram within 30 days, the false positive rate was 32%. Unfortunately, the mortality between the patients who had a false positive and a true positive is actually no different. And that's both when we look at the dobutamine stress echo population as well as the exercise echo population. So all that to say that it's probably reasonable to follow these patients and continue to modify their modifiable risk factors. Whether that ultimately changes their prognosis, we don't know. That study has not been done. But it seems unappealing to just leave them not monitored. And this is our last case of the day. So this is a patient who 48-year-old man who presented to the emergency department with vasovagal syncope. He was subsequently referred for a stress echo. He denies any chest pain or shortness of breath and actually does 4 kilometers of brisk walking daily. His cardiac risk factors are dyslipidemia. Medications are shown. His baseline echo is normal. So as you can see, this apex is looking a little bit funny, and certainly some of the septum is at times looking a little bit funny. So what do you think? This is definite ischemia, possible ischemia, or non-ischemic wall motion abnormalities, or definitely no ischemia? Some of you who have been looking at stress echoes and echoes in general for a while likely already picked up on this, but this patient has a left bundle branch block, and that dysynchrony that we see is likely related to the left bundle branch block, but we cannot be absolutely certain. And so when this study was reported, we weren't certain. What do the guidelines recommend we do in this situation? Well, if you look at the Canadian stable CAD guidelines, which were published in 2014, the recommendation is that patients with a left bundle undergo a vasodilator myocardial perfusion scan. Now, when we look at the data, however, and compare stress echo to MPI, their diagnostic accuracy is actually on par. So MPI tends to have a slightly higher sensitivity, stress echo a slightly higher specificity. When we look at which one is better at predicting outcome, they're both about similar. So it's probably reasonable to do either test, but maybe it's just simpler and more appealing to do a coronary CTA, which can give you anatomical imaging, and you avoid all the limitations that we have with both of these modalities in the setting of a left bundle. Looking at prognosis with a left bundle, the patients with a left bundle have a higher prevalence of CAD, so it's actually very reasonable to consider working them up for it. They also, CAD or no CAD, do have a higher mortality compared to patients with no left bundle. And fortunately, stress echo can help us refine their prognosis. when about 7,000 patients were followed over approximately 10 years, they found that patients who had a normal stress echo with a bundle had a very similar mortality to those who had a normal stress echo and no left bundle. But patients who had an abnormal stress echo in a bundle had a significantly higher mortality than these two groups did. So it's reassuring that even if you do have a left bundle patient, but a normal stress echo, that their prognosis is probably quite good. And I think we have run slightly out of time, but I think this is an important topic, so I'll just finish off on it. The ischemia trial sometimes has made people question, you know, are we going to become obsolete as stress echocardiographers? And I think probably the answer is not, because the ischemia trial by design did not evaluate for the value of ischemia testing. There was really no control group that didn't undergo ischemia testing, and there was no group that had gone ischemia testing and had a negative stress test. So I don't think that this answers the question of what value we assign to ischemia testing. The trial does highlight that, you know, there is definitely a clinical relevance to pursuing coronary CTA, and it lends support to the recent ESC and NICE guidelines sort of preferring CTA as an initial modality compared to stress echo or perfusion imaging. But we have to be mindful that not all patients can undergo a coronary CTA, including our CKD patients. There are a number of patients where coronary CTA will have a lower diagnostic accuracy, that being in those with significant coronary artery calcium, those who simply cannot achieve a low enough heart rate for a gated CT. Additionally, we have CTA as a very resource limited modality in Ontario, at least. So I think for time being, there is still certainly a role for stress echo in our ischemia testing briefcase. And thank you. I'll take questions if you have any.
Thank you, Vesna. It's a very comprehensive, and just to remind everyone, you know, to fill in your evaluation, and you have any question, please type into the chats. And judging the fact that everybody stayed, it's a very, very good presentation. So my comment is, at St. Michael's Hospital, we're actually getting a treadmill, so it should be arriving sometime in July, when we start the new academic year. It's been a long time coming, so we actually will have a treadmill and a bike at the same time. So usually then we selected patients. Usually we tend to do most of our tests on the treadmill if we can, but for selected patients, especially when they have like back pain or especially very highly functioning athletes whose heart rate drops really quickly, bike actually serve a great purpose. Plus, we need to do valvular assessment when we need to get the RVSP and also the transmitral gradient, things like that. That's also very useful. So that will be another topic for another day, to have a stress echo in evaluations of valvular heart disease. Any other questions, comments from colleagues? Well, without further ado, yep. So go ahead.
Sorry, if you have time, Vesna, did you, in your preparation for this talk, did you come across data with regards to patients who are ECG positive but echo negative and the implications?
I did not come across that in my reading, but I will look into it. Have you looked into that?
I think it's something that comes up a lot, and I think it has two potential implications. One is the classic false positive ECGs, where I think the patient still has a good prognosis. I do worry about times where it does impact on the prognosis, but given the results of the ischemia trial, I think ongoing medical therapy, adjustment of the modifiable risk factors, like you said before, is probably still the best approach. You kind of go back to the patient and decide what their overall risk is and tailor your therapies there. But with a negative stress echo, depending on symptoms, you're probably not going to go forward for either a CTA or invasive coronary angiogram.
Yeah, I wonder, I think this is the only kind of slide that I have that is related to your question, where it is a normal exercise stress echo, but it clearly looks like patients with a high Duke score would have, and I wonder if that in part has some, like the ECG has some implications here.
Yeah, it probably does actually. I was actually going to ask you about that because you use the term normal exercise stress echo. I think most of us think about a normal exercise stress echo that's clinically ECG and echo negative, but perhaps the study was only echo negative. Is that correct?
Yes, yes, that's correct.
Okay, then you're probably right then. Yeah. Thank you.
Yeah, I must say I don't have data on this. Probably worth actually investigating. It's I mean, all of us who have done stress echo for a long time have stories about patients being clinical equivocal, maybe clinically negative, and then electrically quite positive, and then echo negative. And you know, traditionally we may not further investigate them. We'll just say that, well, it's falsely positive. But then, you know, sometimes stories come back. Well, the patient 6 months or a year from now, you know, find out to have significant blockages, or even shorter than that period of time. So now, you know, as a n equals to 1 story, when I have patients who have electrically very positive, I would still tend to send them along for some kind of coronary anatomy investigation at this point. But it's really worth investigating. How many things do we actually missed by echo while the ECG is really positive?
Mm-hmm.
No, for sure. I think for all of us, if we see a very positive ECG, we really take a super close look at that echo component and our, you know, our reading might be obviously you know, don't want to bias yourself too much, but you want to be convinced that it's truly negative if you're going to call it.
Yeah, but even that, sometimes it can be a falsely negative stress echo in terms of the echo images. So you know, we have those stories, unfortunately, but we haven't really quantified it from a research standpoint.
No, it's true. Thanks, Vesna. Great talk.
Thank you.
Thank you, everyone, for staying on. So this will be recorded, and I'm sure there's a lot of data to be reviewed. So have a wonderful day, everyone, and I'll let you get back to work.